Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Akebia Therapeutics, Inc. This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein.
Hello, I'm Dr. Wolfgang Winkelmeyer. I am the Section Chief of Nephrology and the Gordon A. Kane Chair in Nephrology at Baylor College of Medicine in Houston, Texas. I would like to welcome you to this program, which is titled The CKD Checkpoint, Keeping Current in Anemia Care for Dialysis-Dependent Patients. And I'm delighted to be joined by two esteemed colleagues. Let's have you introduce yourselves. Jennifer, let's start with you.
Hi, I'm Jennifer Branch, and I'm an advanced practice provider at the University of Kansas Health System. And I've been a nephrology nurse practitioner for the past 8 years, in nephrology for 30 years.
What about you, Leah?
Delighted to be here. My name is Leah Foster Smith. I'm currently the Director of Advanced Practice Providers at Metrolina Nephrology Associates in Charlotte, North Carolina. I have been a nephrology nurse practitioner 25 years this year. I'm also the Chief Educationist Officer at Interactive Nephrology, which is an educational company that we developed outside of our practice.
Well, it's wonderful to be here with you guys today. Here's a little overview of what we're planning to do over the next 30 minutes or so. We will discuss key updates to the most recent KDIGO anemia guidelines, which were published earlier this year. We'll have a brief review of the underlying pathophysiology of anemia in patients with chronic kidney disease. We have some real-world case scenarios demonstrating optimal anemia management strategies, and we'll then also talk a little bit about the collaboration in the interprofessional dialysis care team. So let's first review some highlights and key updates in the most recent KDIGO guidelines for anemia in chronic kidney disease. So let's start off with practice point 3.1.2, where it says, in people with anemia and chronic kidney disease, address all correctable causes of anemia, including iron deficiency, prior to the initiation of treatment with an ESA or a HIF-PHI. And so what it lists there is, of course, EPO deficiency or hyperresponsiveness. Iron deficiency is even the title here. Blood losses are always important to rule out, from malignancies, for example, GI blood losses. There's always the chance for shortened red blood cell survival, especially in the hemodialysis setting. Hyperparathyroidism, thyroid dysfunction, bone marrow suppression by inflammation or by drugs. You need to think about ACE inhibitors, ARBs, or malignancy again. And then there's other nutritional deficiencies such as folate or vitamin B12. Very interestingly, in this new iteration of the KDIGO guideline, a change was made in terms of the nomenclature of iron deficiency in chronic kidney disease. And you all may remember and still have this very, very present, that there's this term of absolute iron deficiency and another term is functional iron deficiency. And that has now been changed. The proposed new terminology, instead of absolute iron deficiency, talks about systemic iron deficiency. So typically in this case, the T-sat is less than 20%. Ferritin is low in the dialysis setting, less than 200 nanograms per milliliter. Hepcidin is usually lower, and the treatment for that is intravenous iron. And then on the other hand, we have what we used to call functional iron deficiency, which is now called iron-restricted erythropoiesis. The TSAT in this case is greater than 20%, and the ferritin concentration is also usually greater than 200 nanograms per milliliter. Hepcidin here is higher, and the treatment in this case is also intravenous iron. And we'll learn here in just a moment about the role that hepcidin plays here that helps us also distinguish and understand the difference between systemic iron deficiency and iron-restricted erythropoiesis. Other recommendations are as follows. In people with anemia and chronic kidney disease 5D receiving hemodialysis, we suggest initiation of iron therapy. Ferritin is less or equal than 500 nanograms per milliliters and TSAT of less or equal to 30%. And then in people with anemia and CKD 5D receiving hemodialysis or peritoneal dialysis, we suggest initiation of ESA therapy when the hemoglobin concentration is less or equal to 9 to 10 grams per deciliter. And then in adults with anemia and chronic kidney disease treated with ESAs, we recommend targeting the hemoglobin level to below 11.5 grams per deciliter. So these are some key recommendations right off the tap here. Jennifer, any thoughts regarding this?
Yeah, I'm really excited about the new guidelines. We're now learning more about options that are available. The updated guidelines specifically have emphasis on more of a proactive iron strategy versus reactive. And then also the HIF PHI options truly offer individualized solutions for patients to achieve their best outcomes.
Excellent. Thank you, Jennifer. Leah, what is your gut reaction here?
Um, I think the focus on iron, which has supposed to have been there for a while, but making sure and understanding, does this patient have anemia associated with something outside of erythropoietin deficiency? A new focus around iron, but not over given iron. Some of the upper limits now in these new guidelines are saying 700, and that used to be a little bit. Some of our, organizations could go as high as 1,200 on that. So really having us rethink how far are we pushing the current strategies and then opening up the doors to think through other strategies, I think is my takeaway with the newest iteration.
That sounds excellent. So, what about some greater details here when it comes to pathophysiology of anemia? Maybe Leah, you want to walk us through this?
So, first of all, when we think of dialysis dependent chronic kidney disease, first of all, we typically in the past have had our thoughts go towards erythropoietin deficiency. And honestly, that's still not wrong. As we think of kidney dysfunction and as there's a decline, there will be a natural decline in the production of erythropoietin. But what we see in our dialysis patients specifically, things get more complex. So we may have iron dysregulation. There can be chronic inflammation from various disorders that they have, ongoing blood loss. We know that they get an average of 3 treatments per week, and there is some blood loss during those treatments. We probably do up to some lab draws each week. And that will impact their overall blood count as well. And that you mentioned earlier, the reduction in the red blood cell survival that can go down from the average of 120 days down to 60 days in this patient population, not counting them having functional deficiency. So that's just one part, obviously, of the problem. And then, as you mentioned, we do have this new issue with well, it's not new. I think we have just discovered um, that there is a pathway that we've not thought about, and that is understanding the pathway of hepcidin. And hepcidin is known as the master regulator of iron deficiency. And what we see in chronic kidney disease, in stage kidney disease, is that there is inflammatory pathways there. We know that there's reductions and ongoing reductions in their kidney function, and that will lead to those higher hepcidin levels. And so the problem is that the iron becomes kind of locked away, and that's where the body cannot effectively use it. So as iron gets sequestered in these storage sites, the intestinal absorption may also decrease, and ultimately less iron reaches the bone marrow for that needed erythropoiesis, which is that red blood cell production. So even when we see adequate iron stores in patients, they may not have adequate iron availability for that effective erythropoiesis. So I think that is a key takeaway here. And then as we look through and we see and think about treatment options leading in behind this pathophysiology. Historically, we've all kind of dove in and got those erythropoietin stimulating agents started. They have been our foundation of anemia care, at least up until this point. And we know that they directly stimulate erythropoiesis in the bone marrow, which is kind of replacing our body's, natural pathways there. But we have discovered some different biological pathways, and that brings us into a newer class of medications that we call the HIF PHIs. And the HIF is a pathway. So HIF is hypoxia inducible factor, and that is the body's natural system of kind of sensing oxygen. And under normal oxygen conditions, the prolol hydroxylase enzymes do break down HIF and they kind of keep them in an inactive state. So now that we have these new inhibitors, so HIF PHI, the I being inhibitors, it will allow HIF to remain active and even mimic the body's response to lower oxygen levels. So that means that there will be increases in endogenous erythropoietin production, along with the effects of both iron regulation and erythropoiesis. So now we have a couple different options presented to us as we think through the pathophysiologic states and the different pathways that are there in the body.
Excellent. Well, thank you so much. And these hypoxia-inducible factors, prolyl hydroxylase inhibitors, the underlying science was really a breakthrough, and it got the three leaders of that field the Nobel Prize a few years back. So it's really cutting edge, translated from the bench into the clinical scenario. And so here's another recommendation. Now that we've talked a little bit and introduced HIF PHIs, and so in this recommendation 311, it says in people with anemia and chronic kidney disease in whom correctable causes of anemia have been addressed, we suggest using an ESA rather than a HIF PHI as first line treatment of anemia. And so that's interesting. And it's equally interesting how the work group of this guideline justified that recommendation. They mainly stated that there's simply a lack of longer term data outside of clinical trials for HIF PHIs. And that is certainly the case. While these were very, very large phase 3 trial programs that were executed, both overseas, actually, a lot of them in Asia, and then also in the United States, longer term data are still lacking. And in these trials, there was a suggestion that HIF PHIs are non-inferior to ESAs for critical adverse outcomes, but some studies suggested that at least some HIF PHIs may have a higher risk of major cardiac and vascular events than ESAs, particularly in non-dialysis dependent CKD populations. And so what the guideline work group here proposes is two specific clinical scenarios where HIF PHIs may be considered and particularly useful, I guess. One of which is ESA hyperresponsiveness or intolerance. We've all seen those patients that, we accelerate and increase ESA dosing and they don't really respond. And then the other scenario that they list specifically are circumstances where ESA use is simply impractical. That is, if there are any barriers to, parenteral administration. And so in this slide here, again, taken from the guideline, there's a list of the HIF PHIs that are available at some place in the world. And as it turns out, currently in the United States, only one of those 6 agents here are approved for the use, specifically for the use in CKD 5D on dialysis. The Produstat used to be approved and was on the market for a while, and then for commercial reasons only, withdrawn from market again. And then, so we now have Vadadustat, which is the only approved HIF PHI in the United States. Recommended dosing here is a starting dose of 300 milligrams. And then, it can be increased or decreased over time, depending on the patient's responsiveness. The labeled maximum daily dose here is 600 milligrams. And what's important to say, and we haven't mentioned that yet, in contrast to ESAs as we know them, which are injectable drugs, HIF PHI are oral drugs that can be given per label on a daily basis. And so from here comes the next practice point, which states, do not use ESAs and HIF PHIs in combination. I guess there's no evidence, really. I'm unaware of any useful studies that have studied this specifically, although it's certainly a valid an idea. But again, if there's an idea, it first needs to be tested in an appropriate trial setting in order to substantiate what they do in practice. And then the other rather logical recommendation here is discontinue HIF-PHIs if after 3 or 4 months the desired erythropoietic response has not been achieved. And something very similar probably can be said about ESAs, although that very rarely happens. I've very rarely seen patients actually get completely off ESA if they don't respond to our administration. So then when to avoid HIF-PHIs? There's also a list of practice points here. For example, if the decision is being made to use HIF-PHIs for the treatment of ESA hyperresponsiveness, use the lowest dose that alleviates the anemia-related symptoms or reduces the risk of requiring a red blood cell transfusion. And that goes back to the original label for both ESAs and certainly also for HIF-PHIs. It's mainly about avoiding red blood cell transfusions and all the consequences that come from it, especially when with regards to sensitization towards future transplants in people who are eligible. Then another practice point here is in people with anemia and chronic kidney disease not receiving dialysis, or with those on dialysis who have active malignancy or a recent cardiovascular event or a recent vascular thrombosis. Do not use HIF-PHIs. Again, the same actually counts for ESAs. These are settings in which ESA may not be beneficial and actually might be quite risky. And then finally, the practice point 364, where it says suspend treatment with HIF-PHIs in those who experience cardiovascular events, thromboembolic events, vascular access thrombosis, or newly diagnosed cancer, and individualized consideration of HIF-PHI initiation or ESA initiation based on hemoglobin levels and patient characteristics and preferences after discussions of risks and benefits from treatment. And that really circles around a very, very tricky point in our practice. When situations like this arise, we're usually very willing and quick in suspending, ESA or HIF-PHI treatment in patients who have, a heart attack or a stroke or something like that. But nobody has really been able to give me a solid answer on when is it safe to reinitiate. And this guideline here really doesn't address the point either. So I want to kick it back to you guys. Jennifer, what are your thoughts on this? And what's your experience with ESAs and HIF-PHIs in your practice? Are there any particular challenges that you have faced with either of these options?
Well, absolutely. And certainly some of the things that you just mentioned, and trying to avoid blood transfusions and having patients in the past who are hypo-responders, and just to try to avoid sensitization for people who are interested in having a kidney transplant. Absolutely.
Excellent. Leah, any comments from your end?
Well, I think, there's a conundrum that starts to happen when we get into hyperresponsiveness or we get into a malignancy case or we get into, as you suggested, like a cardiovascular. What are our options, right? We as APPs are consulting with our nephrologist and trying to figure out what's next to do. And it becomes collegial. We're reaching out to the cardiologist, we're reaching out to the oncologist, and we're trying to make a decision together because sometimes there is data that's lacking in what's the best option for that patient. And sometimes it's the catch 22. This particular cancer, they'll probably have a year to live. Is this going to affect, quality of life? So, there are times we give it and times we don't. And I think entering in with the PHIs, it's going to be no different. Balancing what is best for that particular patient with the scenario that we're given.
Yeah, I completely agree. And of course, it's also important to bring in the patient voice. If the patient is able and willing to participate in that conversation, we can weigh these options together with them and come to a joint agreement.
Yes.
Wonderful. So we actually have some case presentations for our audience today. And, Leah, why don't you start us off with your case first?
So I'm going to start us off with what I feel like is probably what many of us, if you're in the in-center unit as a nurse, as a provider, that we see and care for every single day. So this is a 64-year-old man who has been receiving in-center dialysis at your center for the last 4 years. Underlying diabetes and hypertension, most likely leading to the diagnosis of end-stage kidney disease. We know that diabetes and hypertension, number one, number two worldwide. He has been receiving IV iron according to your facility's anemia management protocol. And when we look at these lab values that you're seeing, the ferritin is 825. So that means there's good storage. We're definitely not deficient in the storage area. We look at the transferrin saturation, the TSAT, also good at 32%. So, reading both of those, I'm saying, iron is adequate. I see the albumin is, reasonable. Let's be real. Any of us trying to get over 4, that's sometimes the goals of the companies that we work with inside. But to me, if they're above 3.5, we're probably okay. That, asking questions, no evidence of blood loss, has been on a stable ESA dose. So why is the hemoglobin 8.3, right? What do we need to think about and really being considering kind of next in our thought process when we're seeing and rounding or being the nurse in the unit for that patient and going to address it with the provider when they come back into the room. So, as we have talked about with the guidelines, with some of the pathophysiology, I think where our brains have got to start to look at is this is hyporesponsiveness. We've got good iron store. So, this is not specifically an iron associated issue. So, we have to figure out, is it erythropoietin deficiency? Is it an inflammation? He does have diabetes. We know that that comes with a host of other issues. Maybe something else is going on in another disease pattern. Or is the iron there, but it's not being regulated in the right patterns? Is there a limit in that availability at the level of the bone marrow? And so, clinically, when we're seeing a patient like this, we have to broaden our scope and not just be quick to say, oh, let's give more iron. Is iron really more iron needed? We're at an ESA dose that's stable. Is that what's needed? And really broadening to think about, okay, we do have other therapy options here, and shifting away from just iron replacement alone to understanding the broader pathophysiology and thinking outside the box for our patients in these scenarios. Because it's really easy to lean into just the protocol management that happens, right? And if you're the provider in the room, a lot of times someone else is doing the protocols, and we need to be the provider and think outside the protocols. And if you're the nurse in the room who are doing the protocols and you're making the next adjustment, does it make sense? Is there something different that is going on?
Well, thanks so much for sharing that very interesting case. Jennifer, do you have any thoughts on Leah's case before we move on?
I mean, I would like to reiterate just all of the different reasons why we can have anemia. And when we have the iron already taken care of, we need to look at more things. We need to go beyond iron deficiency to correct the anemia for the patient. It's so important.
Excellent. Well, I always think that these cases are very, very illustrative and, resonate with our audience. And I'm already very curious to hear what the next case might be.
Thank you so much. This is a dialysis dependent patient that's on home dialysis, specifically peritoneal dialysis. So, this case is involving a 60-year-old female, Caucasian, who's seen in the peritoneal dialysis clinic. Upon review of the labs, you and the patient and their support person, if applicable, you know that the ferritin is replete, the TSAT is at goal, so iron stores are sufficient. However, you note that the hemoglobin is below goal at 9.3 grams per deciliters. And that's absolutely lower than the goal, which you should be sharing with the patient at every single visit, at every single time that the labs are drawn. We have them understand that 9.3 is below the goal. We can do better. And that is despite a prescription of self administered ESA. So this patient already was prescribed an ESA, was to be giving it to herself at home, yet the goal of the hemoglobin is not being met. So, whenever we look at peritoneal dialysis, there are meta analysis of studies that have shown significant rates of non adherence with peritoneal dialysis exchanges, with medications, with diet and fluid restrictions. Now, the study adherence rates vary quite significantly from 3.9 to 85% on medications. But we need to make sure that we're talking to our patients saying, are you missing the doses? Are you accidentally giving yourself decreased doses? We need to make sure that we're talking to the patient, making sure that they are not feeling like they're being judged or given harsh treatments or anything like that. We just need to make sure that they understand the reasoning and the rationale for optimizing anemia. So, keeping this in mind, you always need to collaborate with the patient at multiple moments, defining, assessing, and recognizing non adherence for this patient. which can come in many different forms, as we know. We need to explore the barriers and make sure that they're not having pain. And this could be either a needle at the or from medication, burning and pain and stinging from the medication itself. That they don't have physical barriers such as neuropathy or cognitive inhibitors such as inability to calculate or even draw up a correct dose. So, asking all of these things to the patient, asking them, how do you give yourself your ESA? And having them demonstrate and teach it back to you so that you can get a full understanding of what they have as an understanding and where there might be deficits and opportunities. Because the patient may have even things such as lack of refrigeration that's keeping them from optimizing anemia management. Again, reviewing the options, the evidence, and the availability with everyone on the care team, including and especially the patient. Making sure that we know we're comparing ESAs to HIF PHIs with the patients and our peers. We need to make sure that they understand the HIF PHIs may require less dose escalation than ESAs. In trials, they were found to be comparable in safety and in efficacy for treating anemia, and that they have these oral options if the patient so chooses. Also, keeping in mind to individualize the anemia treatment plan and dialysis life plan, including does the patient want to have goals for transplant and avoiding transfusions. This is really important for especially patients seeking transplant, either from living or deceased donor, that they should be aware of potential sensitizations with blood transfusions and educated to avoid transfusions if possible.
Well, thank you so much. I think this is also a very interesting case and one that really highlights an opportunity through this new class of drugs that are oral medications. If the patient specifically is not self-injecting because they're experiencing pain from the injection or the substance, now there's an alternative by giving them something that can be taken orally. Leah, any other thoughts on this case before we move on?
Well, I appreciate Dr. Branch bringing forth and us reminding ourselves to not make assumptions about our patients. We need to have that conversation, that one-on-one engaging with them and or the caregivers because we may not really understand what's going on. We come in, we see a low hemoglobin, there is an assumption you're not taking your meds. And then we are already 2 or 3 steps ahead of the patient instead of stopping. And maybe they just don't like the self injections, right? And the oral would be a much better option. Or maybe they're on the oral and we need to go back to the injections. Again, it is that conversation that matters. We are spending those moments looking at that patient, listening to them, and individualizing the treatment plan because just because it worked in the patient in the other room that's here for their same PD visit does not mean that it works for this patient.
Excellent. Well, I think that's a perfect segue to the third case, which I will present. So, this is a 29-year-old Hispanic male with kidney failure from unclear causes. This patient really presented with kidney failure, didn't have any previous nephrology encounter or actually any other encounters. And so he comes to the hospital, is found to have kidney failure, gets initiated in the hospital, and then after that transitions to center hemodialysis quickly. And so he is found to have a hemoglobin of 8.5, the TSAT is 12, ferritin 175. He has secondary hyperparathyroidism with significant elevation also of serum phosphorus. Also in the hospital already was started on a bunch of new oral drugs that he didn't have previously on carvedilol and lisinopril, calcitriol, and sevelamer. And so he comes and now commences care in the outpatient center, where, of course, with the TSAT of 12 and the ferritin of 175, this patient has absolute iron deficiency, as we used to call it. And he's not profoundly anemic with a hemoglobin of 8.5. So a course of intravenous iron was prescribed and administered, and that actually yielded some positive effect. The hemoglobin increased to 9.1 grams per deciliter over the course of subsequent 3 months. And the nephrologist in this case was not quite satisfied with reaching 9.1. And so they started this patient on Bedadostat, 300 milligrams orally per day. So clearly this colleague decided that this is very much a first line treatment for them. And what's also important is he spent the first 3 months getting this patient iron replete, because one caveat when using vadadustat is per labeled indication, it's supposed to be used in patients who had completed at least the 3 months on dialysis. So patient gets started on vadadustat 300 milligrams daily. The next hemoglobin concentration a month later was not much different. It was 8.9 grams per deciliter. And at that point, during an in-depth conversation between that nephrologist and the patient really shares that he has difficulty taking all these medicines, all these new oral drugs, having not taken anything previously. And so he has like these four drugs, two for the hypertension, two for the secondary hyperparathyroidism, and now one for anemia. And so admits to not having taken all of this. And so it shouldn't be taken as a surprise that if the patient doesn't take an anemia drug, that the anemia will not improve much. And so there's now an alternative, which is termed observed dosing, which is a funny term, but that's exactly what it is. And so instead of giving the patient vadadustat to take it at home every day, you can now, and many of the dialysis providers actually start embracing this, you can actually give it to the patient during dialysis. And there was a recent trial that was published that was designed as a non-inferiority trial, where a commonly used long-acting ESA was compared with two different initial doses of vadadustat given 3 times weekly during dialysis, and that could be titrated up or down. And to make it the long story short, vadadustat was found to be non-inferior with regard to anemia control to that long-acting ESA. And so there's this opportunity now to take this out of a patient's hands, this difficult compliance issue, and actually present the patient with their doses of vadadustat during the dialysis and observe when they're actually taking it. And that's what was done in this patient and my colleague's unit. And in the next month already, hemoglobin was slightly up at 9.3. And I need to follow up with my colleague what happened after that. But certainly that is now an alternative also to consider. It's off-label, but it's supported by a well-conducted trial that actually this can be done instead of daily oral dosing. So what do you guys think about that? Leah, what do you think when you hear this?
It reminds me of treating mineral bone disease where we've had agents that we've done at home and then we move them observed and we see better outcomes. So I absolutely know patients get overwhelmed. It is a lot, especially if you're at the beginning of your journey. And so I think knowing this and for even our audience to know that we have this option to move to observed dosing, I think is even broadening this pathway for us. Because I do think there has been some concerns initially saying these patients with some of them have some non-compliance in the past. Will this, daily dosing at home work versus what we typically give when we push, IV or maybe the sub-Q ESA dosing. So now to have not only oral dosing at home with your HIF-PHIs, but the observed, lots of options open up in my opinion. So I think this is great news. Glad to hear about some data coming out on that.
Absolutely. And I really want to highlight that nobody here is blaming the patient for this, right? I
Mm.
mean, it is an overwhelming situation. And it is, good also for the patient to have the opportunity to be presented with this drug during dialysis, to have this 3 times a week reminder, a friendly nurse coming by and popping the vadadustat and the patient taking it then. So I think it's good from all perspectives. Jennifer, any thoughts?
Oh, absolutely. I'd like to mirror, what Leah said, and just we see so many patients that unfortunately start in this patient's shoes. It can be extremely overwhelming, and it may not be forever, but it offers a great option for the patient to actually be adherent with the therapy and get better outcomes.
Wonderful. So I think we'll wrap up our discussion of these three illustrative cases, and we'll move a little bit and shed light on the importance of collaboration, the dialysis care team. Jennifer, would you like to take us through this last section before we finish?
Yeah, thank you so much. So, this is just highlighting the absolute importance of all of us working together, no matter what role we play. Absolutely, the nephrologists can have shared experience with the NPs and the PAs as providers, trying to really tackle these anemia issues that we can do better with our patients and better at individualizing their treatment plans, specifically and prescribing and monitoring that we know and we can pass this along if the patient needs to take their anemia therapy with or without food. Does it need to be timed around binders? What different side effects should we be looking for, and what monitoring should we be doing? And regardless of what type of anemia, kind of anemia treatment we're using, we need to keep those things in mind. We need to make sure that we're offering options for our patients and looking to see if there's any barriers or opportunities that we can be working on. And in addition to all of these professionals, I would want to add the social workers and the dietitians to see if there's any kind of opportunity that we can have and buddy with them as well. And finally, just to make sure that we understand repeated management of patients with dialysis-dependent CKD anemia allows clinicians like us to develop familiarity with guidelines and nuanced expertise, and improve relationships between specialists, MPs, and or PAs can increase communication outside of formal team meetings. And that absolutely allows for quicker referrals, fewer delays in care, and improved interprofessional trust.
Excellent. Thank you, Jennifer. It completely resonates with me. It's so important to work as a team. Leah, any points that you would like to make before we go to the key takeaways?
I definitely think when I think of these dialysis clinics, whether it's, home or the in-center clinics, I will say from my perspective as a provider, I can't when I come in, I can unify the team. I can let them know that their voice is being heard. I want to hear. I definitely agree being arm in arm with the social worker and the dietitian as well, because they're out on those floors as much as we are. And then leaning into our nurses, we have signed off and given them nurse driven protocols for anemia management and making sure that they understand that part. And then we all turn to the patient, right? And we have that conversation with patient, and then they start understanding, so that each time, or at least monthly, when we're going over anemia with the patient, they're more engaged with their care and they understand, hey, why did my hemoglobin drop? Can you explain that to me? Oh, I see, it's better now. And so I think when we're having those conversations, trust is just developed across the board, and that's the key in my opinion.
Wonderful. Well, so in closing, we have a new guideline. Finally, the old one was a decade old or so. That really has taken a fresh look at how we deliver care for CKD associated anemia in CKD patients and in those on dialysis. And so today we had the opportunity to review some of those new and some modified recommendations. We have some new treatments in our toolbox that are exciting. And I want to thank very much my colleagues, Jennifer and Leah, for having this great discussion this afternoon. And I do hope that this was a useful presentation for our audience. Thank you so much for participating in this activity. And please continue on to answer the questions that follow and complete the evaluation.